Welcome. Welcome to our fourth MIDRC Medical Imaging and Data Resource Center seminar series. Today, we're very excited to have Dr. Judy Chicoya talking on reading race, AI recognizes patients' racial identity in medical images. Dr. Chicoya hails from the Department of Radiology and Imaging Sciences at Emory University School of Medicine, and she is a multidisciplinary researcher trained as both an informatician and an interventional radiologist. She is a member of the Cancer Center there, as well as other society, and is a major player in MIDRC. Her one of the major aspects of her research has been to leverage her skills to build capacity for data science in Africa. And with her research, she brings back to us information on clinical disparities for minimal invasive procedures, methods for validating machine learning models for health in real clinical settings, and exploring explainability, fairness, and specific focus on how algorithms fail. I've enjoyed tremendously working with Judy during this past year and a half of MIDRC as we've gone to investigate bias and diversity and look at potential grants. So I'd like to welcome her to our MIDRC stage and enjoy.
Thanks, Mary Ellen, for the very kind introduction. And thank you everyone for joining this webinar, and also to the MIDRC team, and also a lot of people in the back, and Emily harassing me to make sure that my slides are in on time, and all these wonderful things that make us all amazing. Happy New Year, everyone. And I'm excited today to be talking about this work. And also, if you've had my talk before, hopefully you will hear some new things around some of the additional investigations and sort of the future. And so these are my disclosures. I'm part of funded under MIDRC and also a Nightingale grant through the University of Chicago for open source datasets for osteoarthritis, and sit on several AI committees, but nothing that's going to be affecting this talk. And so I just still want to remind everyone that we're still, the work has improved a lot just because of the public and also many reviewers. So hopefully soon we will finally get it published in a peer-reviewed journal. And so this also work got a lot of attention in the media and a lot of discussions, and that's been just an amazing experience for myself and our team. So we'll start off with a common language. What is self-reported race? Because quite a lot of feedback that we've actually had is around that maybe we should be thinking about race in terms of, is it genetic, and is there an opportunity to explore some of these questions, especially with more diverse data sets. And for the purposes of this presentation, the way we define race is what is a legal and social construct. So here's like, for example, a 2010 census questionnaire in the US, and you'd have to select one box that you identify as. And so in other words, it's how you see yourself, and also sometimes how other people see you. For example, I would identify as African. There's no, when you're an immigrant like myself, there's no African. So I would identify myself as African American, but other people will identify themselves differently. And there's quite a lot of QI issues that you have to think about how race is recorded, and that hopefully will be a future talk for us. And so what's in a name or a label? And I changed my talks to start talking about this because every time I'll talk to my computer science students, or I would go to a computer science department, everyone asks, like, why does this matter? And that honestly blew my mind. And so I usually start with this, so I apologize in advance. And I love to use this example of childbirth, that it's a time of joy for some, and for some is very devastating, where mom and baby are lost. And it turns out that in the US, when you look at the severe maternal morbidity by neighborhood, poverty level, and race, ethnicity, this is data from New York City, you see this group here that's always very, very high. It turns out that just by being Black, you can you experience, irrespective of how much money you have, you experience just very, very high levels of morbidity and mortality. And if you doubt it, that these are two very rich women, Serena Williams, tennis superstar, and also Beyonce, these very rich women who almost died during childbirth. These are people who can afford to get any healthcare that is possible. And just by being Black, their risk of death goes up way, way higher than the other population. So back to radiology and medicine, we know that there's quite a lot of disparities around pain management. We know that some people give Black patients less pain because there's the perception that, we experience pain less, or, and so this is quite well documented. And even in terms of imaging data sets, we see some bias in dermatology. I think one of the Google algorithms is very notorious for this and has been highlighted, that works very poorly for darker skinned people. And if you look at ophthalmology data sets, most of them are from US, Europe, and China, making the tools ineffective for other racial groups and countries. And Ziad here, who does like amazing research, looked at an algorithm being used to refer very sick patients for, additional care. And even if the algorithm did not use race information, it still used a race, a metric that's really tied to race, that is healthcare cost, and unfortunately referred Black patients when they were much sicker to get additional help and care. And so I want to talk about something that I'm very excited about, which is this potential for imaging in terms of AI. One, this group still, Emma Pearson and Zia did this work, and hopefully we'll be reporting our experience on this pretty soon. And they look at osteoarthritis. Now, if you're an MSK radiologist, you know that osteoarthritis, we can say mild, moderate, severe, but the standard, one of the grading systems is the Kellgren-Lawrence score, which is really, developed on a white male population. And so when people have looked at pain disparities when it comes to minorities, what they have found is that there could be internal factors in the knee and external factors outside, like the chronic stress. If you live in a bad neighborhood or you're poor, you cannot afford your basic, your basic needs. And so what they show, they develop what's an algorithmic severity prediction score. So we will see, I predict this, that we'll see quite a lot of work that comes down the pipeline that is going to be based on these predictive markers or triage markers. And I'll show you another example in a few minutes that rely on imaging. And you can see that on three things: on race, income, and education disparities when it comes to osteoarthritis severity, they actually reduce this algorithmic prediction, severity score compared to the Kellgren-Lawrence score, reduces that disparity the most, for almost 5 times, the racial differences. And so, this is interesting. This was done on the NIH osteoarthritis data set. So very, very, it's a clinical trial. So we all know how that type of data is collected. And it's going to be interesting as we start to report on our Emory experience from our own internal data set on the same work. And so when you start to think about the consequences, now, if you have osteoarthritis, I'm not giving you more pain meds because I have my own bias towards back, in the thought of how much pain medicine you need when you're Black, and now you're no longer working or exercising, you add weight, you're no longer eligible for surgery. It sets up this perpetuating cycle that, really affects health disparities. And so they actually look at an outcome where they say, who's eligible for surgery? And eligibility is also tied to compensation and billing. And if you need one of these knee replacements, you know that you probably almost have to pay your deductible before the surgery. And they start to see that when you use the algorithmic, prediction score, that you start to narrow the gap. So, and when you use the same score to look at people who are not eligible, you reduce the number. So this is one example. Another example is work we did collaboratively in part of the validation. This is done by a fantastic postdoc, Adam and at MIT. And this is the MIRI model, which is used to predict breast cancer in 5 years. So if you're a breast imager, then you know that you rely on the Tara-Kruzik model, and you have to go in and find family history and enter these things. No one has, I mean, the reality is sometimes you just are not able to do those things to figure out either who needs more frequent screening or more advanced imaging for screening. And so the MIRI model uses imaging by encoding different views of the breast image, encodes them and aggregates all these predictions. And when the clinical risk factors, are available, comes up with a prediction risk score for breast cancer within the next 5 years. Now I'm showing here something like where the breast cancer would be. It doesn't tell you that, it just tells you the risk of breast cancer. And you can see we show that this model actually performs better than Tara-Kruzik for Hispanics and Blacks. So again, another image-based prediction model. And the last one, this work came as part of a collaboration with a group in Chicago, and actually also part of MIDRC. And we start to look at, could you start to even say the coding of patients? Now you can imagine when you say, well, the patients with more comorbidities are getting worse. And you can imagine in that case, if I'm speaking Swahili, which is my native language, you may have a terrible computer that's translating for you, and now all of a sudden you're not capturing all my diseases. And if absence of a diagnosis code is a health disparity, as even I've shown you, like some of these algorithms that rely on these codes for more resource referrals. And so in this work led by Dr. Ayers, we look at hierarchical condition category codes. These are updated, yearly, and really try to bundle, like similar conditions that should be thought about together. For example, diabetes with chronic complications. And we show that you can use a chest X-ray and deep learning models to really generate probabilities of that code being present. And we correlate it, and I'll show you an example here where we show that one patient was missing a code, and when you do a deep dive in the chart, you start to find that they have the disease, but it's not coded. And if you don't code it, then you're not really capturing the severity of illness, but you're also missing an opportunity to have completeness. And so this is very, very good for minorities and also non-English language speakers, which in clinical sense can make sense. So I've shown you a knee algorithm, a breast algorithm, and now showing you a chest X-ray that can be used all in totality to generate more information. So we expect this type of work to keep coming up. So why am I telling you all these things? Because when we think about these inherent characteristics of the imaging, and the images can encode racial information, now that may be why they perform well for these predictions. We don't know. But if that's the case, then we need to understand that maybe that can help us understand the contribution of the imaging itself on the race information and how it narrows the gap for the disparities. And we all know that, especially now, and especially coming off the Martin Luther King holiday, that just saying race is a risk factor for disease is just not enough. Actually, you shouldn't be saying that. And so we can start to unpack what disparities are. And the other hand is that, what if the models are just using confounders and learning, and we're still thinking that they're working well because they're just overfitting on this race information? So why did we study? This is a big question. Like, why did we study this topic? And one of the things that humbles me about this is that, when these people came out, one of my really good friends said, you know what, I had tried to do some of these things. They were not trying to say, oh, they had this idea before. They probably did. But, they just said, well, Judy, what I felt was like, I should not be a white male in my basement trying to answer these questions. And so there's also this essence of where can we study this type of work and research. And so why did the group study this? We started off, honestly, in what ended up, actually, the special issue I showed you, the last paper, we got a rejection for this work, which was, saying we had looked at text exclusion done by Lale. This is just, you look at true positive rate. These are standard measures of fairness for computer scientists when you want just something standard. And, you want everyone to be a 0, but that never happens. So there's a small range. But when you're above 1.2 here, then you start to be more favored by the model. And when you're less than 0.8, you start to be negatively affected by the model. And I'm happy to report that this work has actually is now published in Nature with more thorough experiments across multiple data sets. Now we know that that this was the mimic data set. So we rarely, in the US, children go to a specific hospital. So I'll be a little more cautious about interpreting this. But for Hispanics and Blacks and patients who are on Medicaid, they demonstrated that they have a very high level of underdiagnosis. So missed diagnosis, if you'd say so. And so this is the paper they've subsequently published. They matched all like 4 data sets, looked at normal x-rays, and a false prediction, a false positive prediction of no finding is what they determine as underdiagnosis, and then start to look at the differences across gender and race. And they start to find that, again, same findings, that if you're Black, if you're female, again, I say this with caution around the age, and if you're on Medicaid, that they find that your rates of underdiagnosis are pretty high. And so our vision here was, Mariana, please feel free to interrupt me if there's a question that needs to be answered immediately. But so this, our vision was to say, look, Emory, in Atlanta, we have almost an equal population of Blacks and whites. We're going to train this model. We're going to test it and just say, we need more diverse data sets. We still do. But and what I like to say now is that representation is not enough. And we thought these biases would go away. Unfortunately, they didn't. And I like to use 2 peak mountains to explain this. So for example, if you had disparities for cardiomegaly, for example, we had a very high rate of underdiagnosis for cardiomegaly among whites. When we brought you to Emory, the heights of the peak dropped, but the pattern still persistent. So this was very, very concerning. And so, when one of our teammates, this work, I'll show you, the big group that did this work is very collaborative, went and said, it's because the models are learning grace. We were like, no, you made a mistake. And it turned out that it's a mistake, but this is how we ended up this rabbit hole. And so we grouped our experiments into 3 things. 1, to quantify the detection of deep learning algorithms. And you can imagine when we started off from a chest X-ray problem, when we found this, we were like, okay, what if we train on hand, right? Will this thing disappear? And then we'll be like, okay, it's something about the chest. And we wanted to see how it works on multiple environments. Everyone who does AI understands the importance of generalization, and then figure out the confounding factors and investigate the underlying mechanism. And so this led us to, before this work, there's only 1 data set. And I know that the special JSR special issue talks about like the limitation of these data sets in terms of diversity. And there's only 1 data set at that point, the mimic data set from Beth Israel, that actually had race information in the data set. And so, but luckily, working with the Stanford group, who have been very, very supportive, we now have in the public domain additional labels for the Czech expert data set from Stanford and the RESPECT, which is the PE subset for the Stanford data set. And this is the National Lung Cancer Screening Trial dataset, and we have several datasets from Emory, and the Digital Hand Atlas dataset was also available. Now, I want to point out that this image here is very interesting because it's acquired by, it's not the native image, the digital image that's acquired. It's an image that's been acquired, then a picture is taken of the image. And so this is going to matter a lot when we come to discuss why. And so the variation of race varied from 6% to 72%. I want to mention here, like in our institution, Hispanics comes under ethnicity, so they're very poorly coded. And the issue about coding race is actually a big debate. And so we're investigating that and hope to discuss that in future. And so we trained multiple models because, like I said, our first initial thing was that this is just a mistake. We trained them across multiple sites and across multiple tasks. And these are the results. We started to find, these are for just looking at Black patients. Can you tell me who's a Black patient? For the internal validation across multiple models, and the external validation, which is, just bringing Emory model to somewhere else. And we've had multiple other institutions test this, and the performance never drops, honestly, which was very, very concerning. concerning. And when we did for the CT chest, there was a slight drop in performance, and we think this is because of pre-processing more than anything else, but we still find we have 6 radiologists on the group, but we find what we would report as superhuman performance for that. Better than radiologists to identify race on at least the chest x-rays. And when you look at other modalities, you can see mammogram is in the 0.78, radiologists were around 0.5 something. And so we still find very persistent high performance. And so, you know, what this experiment was, A3, is to say, okay, let's say I'm going to predict pneumothorax. But in the last layer, you replace the softmax, which is your classification layer, finally, to say, oh, why don't you tell me what the race of the patient is? And we find that you still have race, whatever, I'm going to use race information, but we really don't know what the models look at to really come to this race proxy. And so I would say that most people still end up, we still found that there was this signal that was correlated to the race. These are more detailed subgroup between Asian, Black, and white. You can see everything is in the above 0.9, you know, nines for multiple architectures, and these were run on multiple data sets. Now, you know, there's quite extensive work that has shown that the saliency maps are not helpful for radiologists, and I'm just putting them here to re-emphasize that this is where the correct race was predicted. This is what would be considered as normal chest x-rays, and here's correct race, but this would be incorrectly classified. I mean, honestly, we looked at them, we couldn't figure out what the pattern was. Now, there's some work that has been done by Joseph Cohen, a former postdoc from Stanford University, which is using GIFsplanation for as an explanatory technique. And this is Asian, Black, and white, just alphabetically listed. And you look at the latent encoder space and see what's moving the most and what could account for the differences. So you can see mainly it was around the shoulders, but we know that this finding is not just around chest x-rays, but that's the only information we could glance from there. When we look at the mappings for breast, and especially because we understand that breast varies across various densities, we didn't find much information. I will have to put a caveat here that we haven't looked at the volume of the breast, if that's something that's important. We know some, like African Americans tend to have bigger sized breasts. And then we looked at the cervical spine radiographs that don't really tell us much. And then, you know, at this point, we were like, well, maybe it's the X-ray, the modality, you know, X-ray CT. And so this work was done by Ben Glocker from the Imperial College, who looked at public brain MRI data sets and came back and reported AUC values of more than 0.95. David Young from Stanford went back and looked at echoes and still also came back and said that could still find, it wasn't a 0.9, but was still able to differentiate the different races. So this then threw out our hypothesis that it's most likely just an X-ray interaction, and it was more of the imaging. So here are some of the things we looked at in terms of anatomic and phenotypic confounders. Looking at BMI, we know that varies. Was there a difference, you know, by first training a prediction model, and also just subgroup analysis across various BMIs, and then looking at breast density and even combining it with age and looking at the disease distribution. And the disease distribution, what we did here was to look at the label of the X-ray. Maybe like, could you predict, is pneumothorax more for Blacks, or atelectasis more for Blacks and cardiomegaly more for whites? And we find quite a drop in performance that's not able to explain why we have this very, very high performance when you look at even just like the normal class. We looked at bone density features. I'll put a caveat here. We've gotten subsequent suggestions of how to maybe process the images a little better to look at this. In our experiment and a few more, we didn't see a drop, and we didn't see any difference in terms of the prediction by age or sex. Then we started to look at some experiments, you know, to play around with the images. Here you can see we add noise, then make it blurry. And even if I said that the algorithm, the saliency maps are not super helpful, we figured that if we change our test set, we would block, occlude the area of the most high probability, the race information would disappear. And so when we look at the noisy versus blurry, and you can see the original, we see a drop in the performance. But when I said that the radiologists are around 0.55, we still see that there is some signal even in these noisy and blurred images. And when we block the area of interest, we can see that we have a drop not as big as like the blurry and the noisy images where we see that this area is blocked and you can see that there's still some signal. Then we segmented the lungs and the non-lung segmentation. This was done on the MIMIC dataset, and we've subsequently released this dataset through the PhysioNet challenge, and to look at, is it the lungs or the non-lung segment? And you can see that overall, the lungs have lower signal and compared to the non-lung segment, the soft tissues and that make up the non-lung segment. And then we started playing with the images where we would divide the chest X-ray into 9 areas, and we would, block one area and keep rotating it. And then also take that area that's blocked and just zoom in and see if what the prediction was. When we take the area and zoom in, we find that we have this there's race information in this patch that we found. And when we block it, the biggest drop comes in around 2-3, which is around this area here, where we expect, there's quite a lot of variation based on if you're just doing a proper PA versus a frontal radiograph. And that's our hypothesis, but we don't know why this area, when we blocked here, then the race information, had quite a significant drop more than the other areas. When we look at age, I said that we didn't find a difference in terms of across races and the AUC prediction, and neither did we find a difference between male and white. This is really, so far, I've said that we find very, very good performance of, race detection across multiple modalities. I've shown you some, we can't find a confounder. And the why, I'm still going to show you a few more slides that, talk about the why. And the thing that honestly was very surprising and remains the most concerning is this, application of high and low pass filters, which are trying now to strip the image of very specific features. And you can see, if I showed you this gray image and said this was a chest X-ray, I mean, I don't know that I would convince you, but you see that even in this area where we've applied a high pass filter, we have, above 0.8 race information. How could you encode race information in something like this? Because then it's no longer like the hand where I could say, oh, the algorithm missed a mole on my hand because it was dark. It's because a radiologist will not even be able to figure out what the model is looking at here in the first place. And then we started to change the resolutions, and you can see when you make a 4x4 resolution image, you still have some race information. Now it's starting to get close to 0.5 where the radiologists were performing. And, someone said, well, maybe there could be a mistake on this. And we went back, and this is 1.1 resolution, which is where the radiologists are. And these are barely perceptible to be radiology images, but we still find some signal, but, less than 0.6, honestly, I would take it more of randomness. But the 4x4, we still find some information. These are just some curves and some charts to show the confusion matrices. And then we thought, what's like some common sense type of thing? What if we shuffle the labels, especially, you could shuffle the training and validation data sets. And you can see this is the data set, distribution. This is just in one data set, and start to say, okay, what's going to be your prediction? And then here we start to come to randomness, which is more like, makes more sense. And so it wasn't that there was something about the labels, and there was still just, again, coming back to there's still something in the models. And then the equipment, we know this varies across multiple institutions. So we looked at, our portable X-rays that Emory are done using Carestream. And when you look at an internal test, same hospital, same equipment, we find this is the performance. And then when we test it at other hospitals, we see find there's maybe a change in the Asian performance, but the black and white performance didn't really change much in terms of when we introduced new equipment. And we tried this for looking at views, like who gets what views and what hospital. This is looking at the breast data set. In our institution, we usually mainly use Hologic, and you can see, because, for example, you could say, well, maybe the patients with big BMI are scanned on one scanner, not unreasonable because of the weight limit of scanners, or maybe that, so you could start to imagine how systemically someone may end up being imaged in one hospital more than the other. And in that case, when we come here, then you can see this is the Hierarchical for the 2D views. Didn't change much in terms of the prediction, and also when we changed the the medical equipment, we didn't get a big difference. Just something else showing you like the location of the hospital and the curve. So there's something about this pixel, and we still have some work we've made some progress with this work, that maybe there's something about the pixel. And you can imagine then maybe we could say, even if with our resolution or our high pass and low pass filter, that the bone density pixels still have some signal, and that's why things are working that way. And so the way we ended up sort of fashioning this experiment is to start to use the intensity thresholds of what we think is normal air, fat, soft tissue, and bone, and start to apply that to the imaging, and then see what the predictions were. And overall, they came around randomness, but we know that this is something, at least when we've looked at some of the earlier results that we have when we look at the raw images, that there's some signal here. Now, I want to just plug in here and just say, this is the reason why this centralized like data collection system and the data processes, for example, by the MIDRC project are super, super important, because then you can even start to have preservation of some structure, for example, DICOM, that allows us to even to go back when we have these interesting questions to answer this type of questions. So if you're not contributing, really your contribution makes a big difference. One other thing, initially when we're thinking it's mainly X-rays, was that maybe it's the interaction of melanin and the skin and the X-ray. And so luckily, Matt Langren had done this work, which looked at the checks expert and took iPhone and Nokia images to try and get like a checks photo data set. And you can see the distribution for that data set. This is an example of a similar image. This is the original image, and this is a checks photo. And I talked about the digital hand atlas, which is again, appears the same way, where you're taking a photo of a medical image. So in this one, obviously there's a small training set size, and we compare the performance. This is the original. So it's like the same apples to apples, and you can see a slight drop when we digitize the images, but still better than radiologists. And then one other thing that we've been exploring is this, when you're doing, transfer learning experiment, this has been done by one of our fantastic students, Brandon Price, who, usually you're coming in last and using the weights, you're not randomly initializing the weight. And this is also, again, a big call for like the medical ImageNet, like just not initializing weights from cars and airplanes and wherever object is in the general universe. And we see, when models initialized with ImageNet nets, weights and trained fully for race detection usually perform better than the random weights. And the one interesting thing in this experiment is that we start to see when we do a different task, for example, APPA detection. Remember I'd said a disease detection task previously. We start to see a difference actually based on how you initialize the weight. So there's some signal here, and we hope that we'll be reporting this after we complete our experiments about this. And even we saw that even specific pathologies, for example, cardiomegaly, edema and diffusion and support devices, improve the transfer learning to race detection when compared to some other lower performing pathologies. And thanks to our physics colleagues, we got some phantoms. Honestly, in my mind, I expected the phantom to be white, but it turns out this one in Atlanta is not. And this does not have real human bones. Now they use 3D printing for this. And we took some CT scans. They were very generous to try and do several protocols. And this is the same image, same person, and you see quite an extreme. And if you look at this probability, it's like, yeah, I think that this part of the slices are one race versus this other part of the slices are another race. Well, we expected that, most of them would be somewhere here, which is like in the randomness area, but that was not the case. So quite a lot of work to be done to explore the phantoms. And then This work is done by Poche and his team. This is our collaborators from Taiwan who start to look at how you can manipulate the images. So you can see the original image. This work is accepted in the AAAI conference, and the Otsu thresholding and Gaussian blurring and noise, but I'd shown this before, and where you crop, like you zoom in into sort of like one area with a large, medium, and small. And what we find is that when we look at the Sobel filter, we see the outlines matter, the pixel intensity. Whenever I said some other data is trying to show us that maybe they matter, and the details of the outlines are important. And we maybe think that it's something about the contour and the shape, but we really don't know. For chest X-ray, it could be just the shape of the chest, but it may make sense why like the lungs had lower performance than the soft tissue, but honestly, these are just my hypotheses and have not been proven. But this was one of our earliest things. And then we started to do like these transformations, and we've done quite a bit of work on this, honestly, that looks at shearing, and we know machine learning. We spend a lot of time with these transformations and what their impact is on this detection. And most of them are just low. There was never anything high in terms of like rotating or sharing or scaling or fisheye distortion. So this code is available. Like I said, we've gotten quite a lot of feedback from the public, and it's just been an amazing project to work on. And again, I talked about the superhuman performance of race detection on imaging. I talked about why the context is important as we start to see more predictive models that are just image-based. This is a phenomenon that we need to understand, whether it helps us or it doesn't help us to really move the field forward. We really could not find we haven't been able to find the clinical confounders or anatomic explanation. And there's really a critical role for really curating very diverse data sets, and also thinking about better explainability techniques and deep learning models. And maybe this is the tipping point where we decide that it's finally a call for the medical ImageNet. I'm involved in actually a writing project to think about what policy would look like, because if you think about the current regulatory landscape is still lacking and doesn't provide clear guidance on what to do. There's some things coming up, but doesn't provide clear guidance on what to do with these disparities. I wanted to end, so we are ending also with a federated learning project. We have 8 institutions. This is going to be amazing. It's just an amazing project, and I'm excited about to see what we end up there. We've developed some work. I didn't show that today, showing the use of adversarial debiasing, and that's been accepted in AAAI. And still quite a lot of work to be done on explainability. And this part we haven't really moved as much as part of the group. So this work was done across 6 universities, 3 continents, lots of computer scientists, lots of medical residents, undergrads, just a very diverse team. And I cannot just really understate the importance of this diversity. It makes your research better. It makes your research enjoyable. And, I see the same also in sort of like this growing network of around imaging AI experts, even in a project like MIDRC, that really just is an amazing way to do science. You can look at this paper that we wrote about how we use the MIT critical data experience to grow communities and grow and advance the data science field. This is part of my group. We've expanded. We're always looking for people to work with. And so I'm looking forward to the discussion. Thank you so much again for the invitation.
Thank you, Judy. Great talk, and I'm sure it's bringing up a lot of thoughts and questions in the audience. We're going to go to the questions now. I just want to say, I really appreciate how you have the results, and now you're trying to figure out why. I think that's really important, not just to get the results, but to good investigative. So we're looking forward to more and more from you. We do have some questions. We have a question from Andrei Fedorov. How do radiologists approach identification of race from images? I thought Dr. Chikoya mentioned the model performs better than radiologists in this task, which I assume means radiologists have a way to attempt determining race from images. So what do radiologists think when they're trying to determine race?
Thanks for this question. Honestly, we never we never consider it in our workflow. I'll be honest. It's because we had so many radiologists in the group. We decided, why don't we do a test? Now, one of my students has said, why don't you provide a conscious bias training and then force the radiologist to do the test and see maybe there's something that we identify that we don't usually identify. And but the truth is, normally you're reading so fast, you only care about the history, and the history provided in the radiology report is usually, it's not like 65-year-old African-American male. Now, I'll tell you things that can bias you from the report. One is names, right? So if you see Gichoya, then it's not a common American name. So you may be like, oh, I wonder where that name is from. Or sometimes, and this is a really bad example to give, but when you had at least when I was a trainee and you had, let's say, a male, so we can tell male and female unless people are transitioning, their gender. But when you would find like nipple rings, and in a male, so people may think that those tend to be gay men, and so may even specifically report on pneumonia, like PCP, like pneumocystis pneumonia, or you start to think more of like the diseases that more affect a specific population. But most of us, and we don't read the clinical EMR note, for every case, unless you're a cancer doctor who's trying to figure out, okay, what's been going on with this patient. And so overall, we don't really use race. The reason why I tell you that this was better than radiology is just because we ran an internal test and just had everyone look around 50 images to figure out if they could figure it out, and we couldn't.
Thank you for that answer. Another question from Bob Nishikawa. Have you tried using CGAN to convert an image from a Black person to a white person and then take the difference?
Yes. Actually, this work is being completed by 2 of our students. So we've used cycle GANs, and we've also used style GANs. And I will tell you the big takeaway is that everyone is converted to white race signal. Even whatever you end up doing, you move the Black patients to the white patients. Unfortunately, not unfortunately, but again, maybe explains why. I don't know why, but we've ran multiple experiments. We've run across multiple data sets. We've applied the style to even get this mixed race where you think that everyone comes into the middle. It's not the same. And so we will be publishing about that work pretty soon. I know that we just reviewed it last week with my students about it.
So when you converted Black people to white,
and the reverse,
and then ran that look at the result of the chest image.
Yes,
they're predicted as white.
Yeah.
And when you took white and converted to Black,
they're still predicted that.
Interesting, very interesting.
Yeah. So
okay, we do.
Could be something to do with the calibration, but again, me and Mary Ellen have had this discussion. It's very hard to get raw images, raw before the pre-processing, and we'll hopefully leverage, and hopefully some of our physics experts here, like Mary Ellen, are on the are thinking about how would we even develop such a data set that would allow us to even ask this type of questions. The one thing I'll just go back to the GANs is that we had actually interesting results, because you could imagine, like, maybe you didn't have a test tube and now I've applied another style and it could transfer pathology, but we control for all those things. And we know that there's quite a big push, even if it's not really taken over, about synthetic data to increase the amount of data sets that are there. But I still think that, I didn't put them here in the slide one because it's still like work in progress and we're trying to figure out what that is, but we've been working on it quite to see the same consistent results. And but we find that maybe, and we haven't looked at this, is maybe that the synthetic data may still have this type of signal, but we don't know. That's why we're putting this out there so other people can work on it.
Okay, Bob added to his question, what about biracial people?
So
where do they fall?
That's a great question. So like mixed race. And I'll tell you that this is a big gap for for the healthcare system. Now, in the federated learning project, for example, one of the institutions is Mayo, and Mayo is very, very detailed about how they record their race information. In fact, it's not just Asians, it's Asian Indian, Asian Chinese, you know, very detailed, versus somewhere like Emory, where you cannot even have two check boxes that say, or maybe identify as, you know, white and black, you know, somewhere in the mix, so, or a mixed race. So this is a fundamental flaw in how the EMRs are designed and how the data is captured. So one of the projects that we are going to do, we haven't done this, is to prospectively collect the patient voice in how they see themselves. And also, could you maybe, like the society, and this brings up like a ton of ethical questions. So for example, could you say that that the race information, you know, like I should be allowed to change my race? And if it's the social and legal construct, maybe I see myself as white, you know, and so what does that mean? And so there's quite a lot of ethical questions that arise, and I'm glad that there's also like, you know, this field, and we're starting to think about it. But I'll tell you, one project is that at Emory, we collect pictures of patients when they take their point of care radiograph with their x-ray. And we really had that data set to look at the identification, but we are going back to really look at skin tones, because we know that that fails across a spectrum, to start to figure out, are there new groupings that would even start to account for the various differences. Otherwise, this is an important question, because if all your data is, and all your questions are based on the EMR data, I'll tell you, for example, Indians get grouped as white quite a lot, and we're starting to think about how to rethink this collection of the race data.
So Judy, there is, besides many people in the chat saying what a great talk this has been, there is one question hiding in there. And it is, I know we have to end this very soon, but I'm gonna read it. Is the usage of Serena Williams in Beyonce as example for race disparities associate only with race, or is it likely a combination of race and VIP syndrome? And they reference the Chess Journal, beware of the VIP syndrome. So it would be, I guess there you would have to subdivide your races into socioeconomic status and all.
Yeah, the New York neighborhood, the one.
Comment?
Yeah, the one I quickly showed, though, the SMM neighborhood data from New York shows that irrespective of poverty levels, education levels, Black mothers die more than any other race. And even in the hospital, it's a known fact if you take care of mothers. I just used it because sometimes people are like, oh, really? And, you know, also, I'll tell you, one of the most challenging things has been working on this topic is that people think, the computer scientists want one definition. They just want one, show me one use case, show me how it's biased, and I'll fix it for you. And that's the wrong way to approach this problem, because we can't even, all of us agree on what fairness is, you know, even when you think about something like medical imaging. And beyond that, when you agree finally on what fairness is, which is still a work in progress, is, you know, it's fair for whom, you know, and so again, a lot of things, bigger things to think about from an ethical point of view, and also moving away from a technocentric, you know, like, oh, I just have these metrics that I met and my model is fair, to more thinking about clinical outcomes, and also thinking about the non-engineering people who work on this.
Okay, so I think we're going to be, I'll just quickly ask you, it's related to Andre, other question here. When you did all this training and testing, you know, in chest images, there's multiple views. In CT, there's multiple slices. The question is, when you did training and testing, was that by case as opposed to image?
So for the cross-sectional testing, what we did was we were using 2D series. So we did per slice, per instance, and then for when it's like a CT test, then we can aggregate. So we report both results per slice, and we, in the supplement, I don't include it in this, but if you look at the supplement documents, and honestly, the preprint even is not as updated as with what we have subsequently done, is that you can see like where the top of the chest X-ray and what slice, right, and what the prediction. So you can see from top to bottom how the predictions were. So we use that.
But all the slices in a scan were either in training or testing?
But we separated that the patients never crossed. There was no data leakage.
Okay, yeah, that's what I assumed, and that's what he was asking. So yes, good. I think we got all the questions answered. I know we're running beyond the time limit. I want to thank you. Great talk, great conversations through these questions, and we look forward to all the publications.
Thank you so much. And a shout out to Susan from the NIH, who's the director of the ODSS, who even joined our call today.
Yes, and I should have mentioned when I introduced you, they're from Emory, but also percentage of your is from NIH scholars. So data science. So thank you. See y'all.